Good morning, good afternoon, and welcome to this new edition of VAER webinars. Today's webinar is about automated near real-time vent data and how this data and the feedback from this data may help reduce incidents of ventilator-associated events. We have a panel of two speakers today. We have Mr. Harold Oglesby, Pulmonary Medicine Manager at St. Joseph Candler, and we have Dr. Steve Cataldo, Director of Anesthesia at Caremount Medical. Dr. Cataldo, Harold, welcome and thank you for joining the webinar today. The floor is all yours.
Excellent. Thank you, Maya. Thank you to the VAER team, to everyone that's hosting this. I think I speak for both of us when I say we appreciate the opportunity to speak to everyone here. How we're going to break it down for the day or the morning from where I am anyway, is I'm going to speak briefly about a study that Harold and I did together at his institution, looking at a nice piece of electronic technology, and talk about our methodology, talk about our results, a little bit of conclusions, and then I'm going to give the floor to Harold to talk about his personal experiences with this type of product in his institution. I'm going to go ahead and share my screen. Before I do that, hold up. Okay, share my screen. Very good. I'm going to go full page. Okay, beautiful. So the title of the paper that we studied was called Automated Near Real-Time Ventilator Data Feedback Reduces Incidence of Ventilator-Associated Events. All right, this was a retrospective observational study. I'll talk about it in detail, start to finish. So let's just start briefly. The care of mechanically ventilated patients. This is a super, super complex process. I think we all know that. Everyone on the call probably has a very close relationship with mechanically ventilated patients. All right. Three big, hard hitting home things that we need to do for the mechanically ventilated patient. We need to treat the underlying disease process. All right. What could that be? That could be a slew of 1,000 different things. All right. We got to make sure that whatever's ailing the patient at this particular time, that we're starting to treat that underlying disease process. Of course, we want to maintain cardiopulmonary homeostasis. All right. We want to keep them hemodynamically stable, keep them oxygenated, allow their body to, heal itself as we, intervene in ways that we know how to with modern medicine. We have to support patient-induced recovery and rehab, meaning we can't just do everything for the patient. We have to allow the patient to, help regain strength and heal themselves and really just kind of support their own natural healing. I mean, modern medicine is amazing and we've made huge strides over the last 100 years, but we know very little about how the body truly works if you come down and think about it. All right. And then, how do we do this all? I mean, this requires a complex team of multi-specialties. I mean, we have the ICU team, we have the nursing team, we have the respiratory therapist team, we have infectious disease, cardiology, pulmonology, renal. I mean, there's so many different teams that we need to be coordinating all at the same time to really enact this and really make this happen. All right, we have lab data that's constantly changing and trending. We have pathology data that comes into play and changes our management. All right, we have advanced technologies like ventilators and infusion pumps and different medications that are coming on and coming off and this and that. This is a really kind of complex array of different things that we all need to be sort of combining all together, creating a story that's easily readable. And that's not always so easy. All right. So while we're doing all of this, we have to make sure that we avoid the complications that arise from the care itself. All right, which is very difficult to do. This is a lot of different things happening all at once. So what I'm really talking about here and where we're going to focus a lot of our energy this morning is on those adverse events, particularly the ones arising from the ventilator. You can almost think of them as iatrogenic, right? I mean, we're putting a patient on a ventilator, and then the ventilator inherently is, helping, but also potentially hurting the patient or causing harm to the patient. And we know that ventilator-associated events, here as defined by the CDC, it's usually the easiest definition to use, will increase morbidity and mortality in the patient, and of course will increase cost to both patient and healthcare facility. So I won't go into too much detail as to how the CDC specifically defines each of these ventilator-associated events, or what we will, heretofore call VAEs. But these are symptom and syndrome definitions that the CDC has put together to help us identify an adverse event. Usually includes things like worsening PEEP requirements, worsening FiO2 requirements, things like that. Of course, fevers and known infections, consolidations on X-ray, all of these different things kind of come together to create these definitions of ventilator-associated conditions, infection-related ventilator-associated conditions, and then, of course, probable ventilator-associated pneumonias. All right, these are huge, huge killers. They definitely increase morbidity and mortality, as said, but really it's something that more so is tracked. All right, because they're easy to define as a constellation of symptoms, and they're easily identified with some data. Whether that's easy or difficult to go and get is another question that we'll talk about. But they are easy to define, which means they're easy to track. And by tracking them, of course, most healthcare facilities are going to know their incidence of VAEs, and then again, their inherent costs. So what has been done and what is current practice looking like? All right, there's a lot of different protocols and what we call guidelines and best practices that are out there. You're looking at CHEST, you're looking at AARC, you're looking at a lot of these big organizations putting out, sort of best practice guidelines and protocols to effectively minimize the length of time on mechanical ventilation, minimize the incidence and prevalence of ventilator-associated events. And again, these are just a constellation of different ideas, practices, protocols, different types of things that we can enact to that have been shown to decrease length of time of mechanical ventilation. Now, when you comply with such an advanced and effective protocol, it has been associated with rapid liberation from mechanical ventilation. Of course, it's been associated with a reduction in VAEs and a reduction in healthcare costs, and it all sounds kind of fine and dandy. But what really, when it comes down to it, these things are not so easy to apply in a real world. When you look at these studies, looking at these best practice and guidelines, these are major, major, major prospective controlled studies that are instituted within a facility or even multi-center type facility, and they have dedicated resources put in place to enact these protocols. All right, now that's a good thing, because then we get to see what is best, right? And given basically unlimited resources, can we decrease mechanical ventilation or length of time on mechanical ventilation? Can we decrease VAEs and decrease costs? All right, if we have research assistants specifically dedicated towards monitoring this and giving feedback to physicians and RTs and nurses and multi-specialty teams that are and helping to coordinate spontaneous breathing trials and awakening trials, and decreasing sedation at the right time, so that these can be really effective protocols. All of these things, they have dedicated resources put in place during these controlled prospective studies in order to basically ensure that protocol compliance and enacting this exact guideline or best practice that they're talking about is put into place. Now, in the real world, in my world, Harold's world, in your world, this is not the case. We don't have all those people around monitoring this, giving us feedback, showing us exactly what's going on, collecting all the data from the medical records, from the lab, from x-rays, from pathology, from the vent, what's going on with the PEEP over the last 2 weeks, things like that. We don't have all that information. Now that information exists, right? It exists on the medical record. It exists by trending things on the ventilators. I mean, this information is out there. This is how a hospital is able to identify VAEs, usually way retrospectively, right? They look in the future at how many VAEs we had last month or 2 months ago, all right? And what we see is that when these best practices and guidelines are instituted in a healthcare facility, the outcomes often don't truly reflect that same level of excellence, if you will, as those prospective studies. And I think ultimately that's a problem that we need to be evaluated, right? If we know what best practice is and we know that best practice works, how do we get that to work at my institution, right? How do we get that to work, at a rural community type hospital, not just, the major academic centers of the world, right? I mean, if it's not applicable to the real world setting, how good is that information, or how easy is that to enact? So that's what we're going to be talking about with RKP here. So before I do that, I want to ask a few questions to the group. We're going to set up a poll, Maya, if you don't mind helping, which is, at your institution, do you have someone, first of all, is there someone that's specifically tasked with identifying and reporting VAEs? I encourage you, please answer on the screen, submit your responses. All right. The question I'm really asking here is, do you know if there's someone looking at this? Are you getting a report of this, even, retrospectively, even for last month or 2 months ago? Is there someone telling you the incidence of VAEs in your hospital? We got a result on that? Okay, good. So that gives me a little bit of a baseline as to where we're working here. 63%, say 2/3, know definitively that there's someone doing this and looking at this, all right? Quarter say, I don't know, and then, only a small percentage say, absolutely no, there's no one doing that. So, all right, this gives me a baseline to know that, all right, we know that this is being tracked, right? We know that this is important to the hospital system that you're currently working in. All right, so how can we then help you as sort of the frontline provider, all right, who's on the ground level, to treat some of these things? The next question I have is, all right, knowing that information, what's the incidence of ventilated patients that present with VAEs? Is it 5%, 10%, 20%? No, 0? We don't have any VAEs in our institution. I mean, what do you think? And how is it looking at your hospital? All right, let's see what we got. What do people actually think is happening in their hospitals? Okay, good. That's probably spot on. All right, 44% say about 5%, 32%, 10%. So that's already covering about almost 80% of people think it's somewhere around 5 to 10%. And you know what? You're probably right. All right, you're probably right. It's probably closer to that 10%. It's, it could be as high as 20%. It could be a little higher than 10%. All right. I probably doubt that there's none, but maybe you do have a good system set up and your VAE rate is very, very low. All right. But I think this is, I think so. This tells me that we're all kind of on the same page here. if we're looking at about 5 to 10% of patients having a VAE, and a VAE increasing, costs, even if you just look at costs without morbidity and mortality will change based on severity of illness and things like that. But if you just look at costs across the board, if you're looking at, say, 8% of patients in the ICU across the country having a VAE, at somewhere around probably $40,000 per VAE is what most, the Cochrane reviews are looking at. It's a lot of money, all right? And certainly for your healthcare institution, these are definitely things to try to be avoiding. So let's continue on and talk about RKP, which is the technology that we're employing in this study. So Respiratory Knowledge Portal, it's a software technology that connects with a lot of the equipment and monitoring systems within the ICU. The ventilators, vital signs, infusion pumps, and of course, we'll look at some data from the medical record as well, connects directly to the medical record. It helps you to kind of combine and compile a bunch of necessary and, important information. As I was saying before, the medical record has all of the information that we need to be evaluating VAEs, to be looking at patients and seeing how they're doing. But how realistic is it that you're going to go through an entire medical record and specifically find every single data point that you need to make that decision? It's very, very difficult. It's very daunting. Most people would agree that, modern medical records are more a piece of legal document more than a usable system for making medical decisions in many respects, just because it's so difficult to then compile the necessary information and sort of weed through all of the fluff that's on a medical record, particularly electronic medical records. So what Respiratory Knowledge Portal does is it goes and does all that work for us, all right? And it gives an output as a very user-friendly, very easy to read, very easy to use template for seeing how a patient is doing, seeing how they're progressing, seeing how they're trending, and identifying when VAEs might be upcoming or when a VAE has by definition been achieved. And achieved in this sense is not a good thing, right? What it also does is it helps to coordinate a bunch of different teams, such as the nursing team, the medical team, and the respiratory team all together to coordinate spontaneous breathing trials, awakening trials, things like that. So it helps to coordinate a lot of these things that are really important to kind of this best practice or guideline protocols that we were talking about before. So this was one of the original studies done with the Respiratory Knowledge Portal, where we went into an institution and we did a retrospective study, and certainly an observational trial, but we looked at an institution who wanted to take current guidelines and best practice, institute that within their healthcare facility, specifically their ICU. All right, so create a protocol and adopt a new protocol, look at compliance to that protocol, and then look at, of course, how the results, how the patients are doing. So this was broken into 3 arms. We have the pre, as I call it, the no protocol. This was original standard of practice at this institution before they instituted new best practice guidelines and protocols. All right. RKP was put into the system, but it was blinded to the clinicians. It was basically on background, collecting information, collecting all the data from the ventilator, from the medical records that they needed to look at VAEs and look at protocol compliance with SBTs and awakening trials and things like that. There was no protocol in place, so this was just, practice, however they were practicing at the hospital. They looked at it for about 3 months, 50 patients, and then they instituted a new protocol, a new guidelines, a new practice protocol into that institution. They kept RKP blinded, again, to the clinicians, just collecting data in the background, looked to see how well patients were doing with a new protocol in their facility. All right, they did that for the rest of that calendar year. And then they opened up RKP, they unblinded RKP to the clinicians. All right, this was at a central workstation, so it was put onto the computers at the central nursing station in the ICU, and then they looked for another year at all those patients now unblinded. So now the clinicians can use RKP to help guide therapy and use their protocol the best that they could. So what they found was that over the course of time, now introducing RKP, they were able to improve protocol adherence. So how often were patients having a spontaneous breathing trial? How early were they doing it at the appropriate time? Things like that as part of their protocol. Of course, adherence improved greatly from about a quarter to 40%. All right. They were able to decrease the duration of mechanical ventilation. In this study, it was 2.7 to 1.7 days. And I understand that that sounds pretty low, but that was this particular institution. And of course, as a study, it's not totally generalizable, but it's thought-provoking, and it certainly gives us some information and data. And it was able to decrease the ICU length of stay from 14 to about 11 days. So it looked like RKP in general was able to deliver enough information to clinicians in a user-friendly enough interface so that they could then enact it to better the care of their patients, decreased length of mechanical ventilation, decreased ICU length of stay. And graphically, you see that on the right, how ventilator duration, of course, is going down. So this was sort of the impetus behind the current study that we're looking at now, which is can we take this one step further? As RKP was initially developed, it was meant to be put on a computer at the central workstation. It's something that the clinical team would look at prior to rounds, potentially throughout the day, potentially something that they would look at, maybe even print out a little overview and bring it on rounds to help guide their therapy. Now, we know that the mechanically ventilated patient is ever changing, right? Their vent requirements are ever changing throughout the day, throughout the night, from day to day. We know that decisions are made within a multi-specialty rounding type service in the morning, right? Where multiple teams get together, we all talk all at the same time, and we really combine all of our knowledge, and then we can go ahead and enact therapy for that day. We thought, what if the respiratory knowledge portal was available to us where we needed it most, which is on rounds? What if it was real-time or near real-time data? What if we could look at it and see exactly what's happening with the patient right now, not hours ago, not when I checked it before rounds, 4 hours ago, that kind of stuff, what we call near real time. And, just to create a definition on what near real time is in this setting, for you to be able to say real time information is live information, that particular millisecond, what's happening with the ventilator, things like that. Now, RKP is not necessarily there. There's a tiny lag. I believe the engineers could talk to this, but it's probably on the order of a few minutes. Certainly not clinically relevant in the ICU, where changes are not happening necessarily minute to minute. So we call it near real time. What we really mean is this is basically live data that we're looking at here, and it's used where you need it the most on rounds. So let's talk about the study that we did at Harold's institution, and certainly something that he will speak to a lot more later. So between January of 2014 and December of 2015, basically a 2-year time period, we looked at all of the adult patients that were mechanically ventilated for that time period. And we looked at specifically patients that were ventilated for 3 or more days. All right. We kind of weeded out some of the quick, I was ventilated for 24 hours, 48 hours, as those patients are likely to do well and not likely to have VAEs. And really, those are not the patients that we're truly looking at when we think about, increasing healthcare costs and stuff like that. For the first 13 months of this study, the RKP was loaded into the central workstation with his institution's best practice protocols. All right, so RKP is very much individualized the way an institution wants. All right, just because AARC says there's a best protocol doesn't mean that your institution necessarily needs to follow that exactly. All right, so you can institute your own best practice protocols within RKP, and it'll monitor it for you. Of course, with CDC definitions for VAEs and the such, that's already being identified and monitored in your institution. So for the first 13 months, this was at the central workstation. The idea was that if we brought it to rounds, if we brought it to a little bit more of a mobile use, that it would directly impact patient care. So in February of 2015, it was ported onto a tablet type computer. It was given to multiple specialties, and they were using it on rounds with now we're calling near real-time data. So it's automated, everything's already put on there. It's a user-friendly interface, allowing providers to see trending and SBTs and protocol compliance. All right, how well are we actually, complying to that protocol that we want to be complying with? All right, the recorded data, of course, simple demographics, time of hospital admission and discharge. So looking at, hospital length of stay, ICU length of stay, and of course, mechanical ventilation start and end time. Of course, we're looking at VAEs. So those are the big ones that we were looking at, just to see that if we brought this to the bedside and if we brought it to near real time, could we further improve care? So let's look at some results. A little over 330 patients total, 187 of those in the control group, 150 after we brought it to the tablet. In terms of simple demographics, the intervention group was slightly older, 66.5 versus 62.8 years. That was statistically significant, so it's worth mentioning here. Clinically significant, not sure. One of the limitations, admittedly, of the study is that we did not include a severity of critical illness score, like an Apache score or something like that. I think that's something that we would probably do in the future, because I think that'd be relevant to see if one group was inherently sicker than the other. With numbers like this, I wouldn't think so, especially because we took all of the patients over the course of 13 months and then all of the patients in the course of the next 11 months. So it really wasn't any specific picking of patients. So for us to believe that one set of patients was sicker in one calendar year versus another is probably unlikely, but it's certainly something that we should look at, and it's a limitation of the study. The incidence of VAEs was really impressive here. So in our control group, we had about 11.2% of patients had one or more VAE. So, the initial poll that we put out, there was a lot of people who put around 10%, and that's probably accurate. Probably about 5, 10, or 10% of patients are having a VAE in your institution. So we found about 11.2% in the control arm of this group, but found it dropped down to a 2.0% in the intervention arm, which is obviously statistically and clinically significant. Interestingly enough, there was no significant difference in the days of mechanical ventilation or hospital length of stay between these two groups. And we'll talk a little bit about that. And I want you to kind of mull over in your head why you think that might be. If we see such a drastic difference in VAEs, 11.2 to 2.2%, why would we not see a difference in mechanical ventilation or hospital length of stay? Especially given we take this one step further and look at all the patients that had a VAE, control or intervention, versus all the patients that did not have a VAE. All right. So 24 patients had a VAE. So a total between both groups, so that's 7% total. 93% had no VAE. So if we look at the difference between those who had a VAE, those who did not, all right, we found a lot of interesting data, of course, that the ventilation duration was way, way higher, right? 18 days average versus 8 days. All right, so that's a huge difference. And of course, their hospital length of stay was equally as significant, both statistically and clinically, which is almost 30 days, so basically a month versus half a month. So, I mean, what a huge difference in having a VAE does to, ventilation duration and hospital length of stay, ICU length of stay. And this is not surprising. So if there's such a big difference, why did we not see a difference in length of mechanical ventilation and length of hospital stay between the two groups? And my assumption and my thought on this is that it just wasn't powered high enough for that. All right. We initially powered this study at an institution of this size with an ICU of this capacity. This is a medical and surgical ICU that we powered it over the course of 2 years to collect enough patients to statistically see a difference in VAE incidence. All right. But even at 11% versus 2%, we're looking at pretty small numbers. 93% of patients don't have any VAE. So we don't expect that, even though those who had a VAE had a longer length of ventilation and a longer length of stay, that it wasn't just powered high enough overall to look at a difference between the control and the intervention group. So if this was powered higher, I would almost certainly think that there would be a difference that was statistically significant. But, this is clinically significant. If we know that VAEs do this much to length of mechanical ventilation, high ICU and hospital length of stay, we know that this is something that we want to be decreasing. And if this is something that we can do with RKP, that's an important kind of thing that we need to be thinking about moving forward. Again, now can we sort of take best practice, take best protocol that's been out there, that's been studied heavily, and that has been known to be effective, and can we actually apply it to our institution, to any institution, all right, without having to dedicate someone to, basically a 24/7 job of mining the medical record for the necessary and required information and trending it in a way that's easily to interpret. All right, this is very difficult work that RKP is doing in the background for us. So we know that initially that RKP has been associated with improved adherence to protocols, time spent on mechanical ventilation, ICU length of stay, reduction in the incidence of VAEs. All right, and it's because they're able to compile all that information and create a user-friendly interface that can be trackable across different teams so they can coordinate this care. The tablet interface takes that one step further, right? And offers now near real-time analysis of the critical information and puts it where you need it most, at the bedside. So what it effectively does, and this is certainly my thought, is that allows these care teams to better adjust vent settings, coordinate SBTs, have more successful SBTs and awakening trials, and coordinate breaks in sedation, and then really protocol adherence. It allows us to more actionably really adhere to these protocols, because one, it's being tracked, of course, but two, it's available to everyone. So they get to see, you get real time, basically feedback on myself. How well am I doing? And that has been shown, certainly suggested in this study, to be effective at decreasing length of mechanical ventilation, more so with VAEs. So at that point, I'm going to take a quick break. I'm going to open it up to questions about this study, how we designed it, certain things you might want to talk about, certain things you might want to rip apart if you want, before I give it off to Harold to talk about his personal experiences with it. And of course, you could do this through the chat section. You can do this live as well. Any questions for me so far? And certainly we encourage you to be vocal in this session. Why not? Let's have some fun. All right. Maya, I'll give it back to you. If anyone has any questions moving forward with the presentation that wants to be directed towards me, Of course, you could put it in the chat section. And of course, there'll be another Q&A section at the end. And we can go from there. Thank you very much for your time so far.
Thank you, Dr. Cataldo. Indeed, we will have a Q&A session at the end as well. So it gives another opportunity. Harold, the floor is yours.
Thanks so much. And again, I want to thank you all for inviting me to share some of my information, and particularly our real world experiences Dr. Cataldo talked about earlier. And I'm going to share my screen here. And I'm going to talk about our real world experience. So we're like a lot of health systems. We're a multi-hospital system. And one of the things that Dr. Cataldo talked about earlier was who monitors VAE information. In our small system, we have 3 hospitals, and we had different practices across 2 of our hospitals. Where we were automated, one of our sister hospitals, which actually houses most of our ICUs, they actually 40% of their beds are ICU beds. And they had one person that was collecting data for all 4 of the ICUs over there as ventilator VAE surveillance. And that was being collected manually in a huge notebook with him walking around and checking ventilator settings and going through the medical record, again, which Dr. Cataldo talked about. And that was a monumental task, but it also could have led to some bias when you're talking about data versus an automated system where there is no bias because the data is the data. So what led us to move from just having the information in RKP to actually putting it on a tablet and using it at the bedside? And again, the doctor covered some of this, but it was the fact that we were using a manual review process to collect VAE data. And anytime you put a human into the evaluation, you can have errors, you can have bias, and you also have to have that person be available to do it. And we all know being tasked with one thing, it would be easy. But when you have a person that's not just one assignment, they have multiple assignments, it's hard to keep accurate data and timely data versus the automated system. There was also a lack of consistency in the review of that VAE data. Again, if you remember saying one facility, one person reviewing ventilator information for a place that has a CVICU, a CCU, a neuro ICU, a med-surg ICU, with a large number of beds. It's just a difficult task. And the other thing was the fact that you had more than one person reviewing that data. One person would collect it, and then it would go to infection control practitioner, and infection control practitioner will review it. And then we also had folks from our pharmacy. We have ID pharmacists who would review information as well. So you had, when it's multiple people's tasks, it's really nobody's task. And you would have conversations about which patient did have a VE, which one didn't. And whereas on our facility with the RKP, again, the data was the data. You're getting real information directly from the ventilator. So the ventilator information was consistent and it was coordinated. The other issue that we were having prior to our study was uncoordinated multidisciplinary ventilator management practices. And when I was talking about uncoordinated, I'm talking about across the multidisciplinary team. So you have your physicians, you have your pharmacists, the nurses, the ID and the respiratory therapists, and even others managing your patients, sedation vacations, spontaneous breathing trials, patients that were being weaned in different ways by different physicians, and just difficulty accessing the information. Even though we at our facility had it in the RKP, one of the things that Dr. Cataldo talked about earlier was the fact that this information was housed in a centralized desktop computer in our ICU. So you had to physically go to that computer at some point during your shift to review the information. 97% of the time that would occur at the beginning of a shift. At the time the therapists would be given a report to each other, they would pull up the information, review it, look at the patient's VAE trends, and then make some decisions about what they were going to do throughout that day. So the data is near real time, and when we talk about near real time, it's pretty much what Dr. Cataldo talked about, and that's within minutes. When the system is slow, it's about 5 minutes, and even that is still near real time. Frequently, it's almost real time. But to have that data stuck in a desktop and not at the bedside was one of the shortcomings. Even though we thought that we were practicing really good because we had a couple of things in place. We knew one thing for sure. We knew that our bedside therapists would always tend to follow the path of least resistance. So whatever we made the requirement for assessing the desktop data was pretty much the only time therapists would really physically go, and sometimes the only time they would have to physically go to the PC. So if they checked that report, that was the easiest time. It was the path of least resistance, and they may not be checked again until the end of a shift. And that's because it was located on that desktop. The workload for the respiratory therapists, you frequently doing a lot of work with less people and adding tasks to our therapists. Our therapists at our facility always practice at the highest level of our licensure, which means they do a lot of tasks that maybe other places don't do. And to do those tasks, it requires their time and effort and their focus, which took their focus away from some of the information that was being shared through the RKP. And they also didn't have that ability to have, they couldn't take the desktop on them as they were going to the bedsides to review some of the information from the RKP for these patients. And there's a wealth of information in the RKP from the ventilators as well as from our infusion pumps and medication information. So it's one of those things from a managerial standpoint and from our team leader standpoint. We would have meetings and discuss our adherence to best practices as far as mechanical ventilation, arterial line insertions, working with our ECMO teams and all those good things. And we felt as though we had a pretty good system in place that was doing what we thought we were doing, that was adhering to best practices that were out there. And the RKP brought it to our quick attention that it wasn't as good as we thought it was. We were noticing a lot of disassociation in things that lead to patients coming off of ventilators earlier, and that was things associated with getting our patients off the ventilator. The spontaneous breathing trials and spontaneous awakening trials weren't as coordinated as we wanted them to be. Physician assessments of our patients were happening later in the shift than we thought they should have happened. There was some miscommunication, a lack of communication between our nursing staffs and our respiratory therapists. And one of those clear communication issues was dealing again with the spontaneous awakening and breathing trials. It's hard to do a spontaneous breathing trial on a patient who's still sedated, or a patient whose sedation is off, but the patient has received multiple bolus doses. In effect, they're still sedated. And those things became acutely, the staff became acutely aware of that when we shared some information with RKP information. In the VAP assessment protocols, they're monitored continuously. So sometimes what you see at the beginning of a shift at report was not what was happening in the middle of the day. That patient may have started trending towards a VAE or may have been on the second day of a VAE trend. Something may have happened where they may have prone the patient during the shift and then flipped the patient back over and had to turn the FiO2 up, and the FiO2 was never turned back down. And next thing you know, your patient is trending toward towards a VAE, or the patient may have deteriorated and the FiO2 was turned up but never turned down, even though the patient had an opportunity to clinically turn that FiO2 back down. So again, our big catch and focus was the fact that, we thought we were doing everything that we could and had great protocols in place, but our VAE rates were still higher than we thought they should have been. And when we talked to our folks, which we have a strong tendency to believe that the clinical therapists at the bedside probably know more than us folks who sit in the office. And we talked to them, and we talked about some of the shortcomings of workflow and checking data frequently. And one of the things they expressed was, we couldn't check the information as frequently as you guys wanted because we couldn't leave our patient, go to the desktop and check the information. So the next thing I said, should we have computers in every room in our ICU? They couldn't get to the computers in the room frequently because other care members were using those computers in those rooms. So we elected to move to the tablet model so that we can give the therapist something small, easily portable, that they could carry with them throughout their day that would allow them to review the data on a more frequent basis, and particularly as they were doing their rounds and at the bedside. And the data showed a couple of things, but our goal was to ease the access to the RKP data, to increase the frequency of the staff's assessment, to have an increased response to clinical markers. And when I'm talking about clinical markers, the RKP alerts the therapist, the person that's viewing it, even though it may not be a therapist, of particular markers that are set, and those thresholds are set according to each facility's protocols. It could be whether the patient's ventilator settings are outside of lung protective strategies. It could be alarm settings not being set within a protocol. It could be the patient's trending toward a VAE. But those clinical markers will pop up on the screen and let you know that something's changed, something is outside of the parameters that you guys set, and you may want to take a look at it. A lot of the times, those things were known to the bedside therapists, and they would know exactly why the clinical marker was showing, and they would address it and usually make a patient note about why that patient had a marker. There were also times when there were things that the bedside therapist wasn't aware of that happened, that the clinical markers drew their quick attention to, and having the tablet at the bedside aided in ensuring that our patients were being ventilated in the best manner that we could. And it also made it a lot easier for us to share data during multidisciplinary rounds. And it was interesting to watch when the data was being shared, because when the therapists are busy, sometimes the therapist would come to rounds, but not be able to finish rounds because somebody's ET tube may not have been in the right place, or somebody may have had a leak here, or something was going on. I had to take a patient to CT. But with the tablet at the multidisciplinary rounds, they could put up all the information and look quick, fast, in a hurry and assess patients. So some of the things that we also wanted to look at as far as not just VAEs, but for the whole team, particularly from a pharmacy and nursing perspective, was some of the information that was coming out of the infusion pumps that were related to better coordination of our spontaneous awakening trials and a review of sedation practices and a decrease in sedation bolusing in our unit, and then an improved adherence to the VAE practice overall. One of the things we did that we tried, and I don't know if Dr. Cataldo knew this, but one of the things we tried before we went with tablets was we placed all this data on a huge monitor board in our ICU. And the initial response from our nursing staff was related to the Hawthorne effect. Once everybody knew that we could actually see all the information that was coming from the infusion pumps, that was the first thing they keyed on. It wasn't the VAE issue, it was the fact that we could look and we could see every time a patient got a sedation bolus. And we quickly saw sedation bolusing decrease. And it was one of those findings that we're putting patients on spontaneous awakening trials and saying, well, we doing this. Every patient, the number of our patients are not breathing. And we would look at the number of boluses they were getting. So patient would get 3 boluses of medication and then a spontaneous awakening trial. But the patient had so much medication aboard, they weren't going to wake up. And then they would stay in that steady state, which made it easier for some care to happen. But again, this led to some of the things you saw when Dr. Cataldo reviewed the information from our RKP. So post-study, you saw the significant decrease in VAEs, and that was huge. That was huge as a huge awakening for our staff. It was a huge awakening for the whole team. And it led to us looking at the way we did everything. So we shared the study data, and we sat down as a team and tried to figure out, we got this information that it was very helpful. Of course, our infection control team were ecstatic that we knocked down our ventilator associated events. Our physicians, and this is one of the crazy cool things that happened from a respiratory standpoint. Our respiratory therapists always had a good rapport with other folks on our multidisciplinary team. But the way they viewed respiratory therapists during the study and even after the study was that we had a little bit more respect. We had a little bit more input and more valued input in decision makings about what was going on with these patients. And we talked to our physician friends, and we showed them when weaning was happening. We showed them, one of the things additionally Dr. Cataldo talked about was the fact that you didn't see a huge decrease in the ventilator length of stay. If we were to follow the data post this study, you would have seen that we did have a significant decrease in the ventilator length of stay, and it was related to information that was coming from the RKP. And it was secondary to that positive decrease in ventilator-associated events. Because we looked at the whole weaning process, and one of the questions that was asked as a result of the study was, why didn't we see a decrease in the ventilator length of stay? And we figured that, we saw there was opportunities to change our ventilator weaning process. Our physicians typically had a practice of coming in before they went to their offices to do their office practice. They would usually come in later in the day, and weaning would start later in the day. We figured that we could have our protocol match what we thought was best practices and have our night shift assess our patients. The spontaneous breathing trials and awakening trials were just that. And then we took away the we took away the bolusing. We made sure that spontaneous awakening trial was a true spontaneous awakening trial. They would wake the patient, do a spontaneous breathing trial, assess the patient for weaning. And if the patient was met certain criteria, that weaning would start prior to the physician coming. And by the time the physician came, he could make a decision of whether he was going to continue that spontaneous breathing trial and wean that patient. And we saw that there was a significant number of patients that met the criteria that could be weaned, that were being weaned. We didn't take our eyes off of the VAE success that we had. We made that a focus as well and shared that information doing rounding. So for us, this whole process of using the RKP was a huge plus. And I think it was a huge plus not only for us, but also for the manufacturers, and that sharing our information and demonstrating that real-time information at the bedside is a huge plus. And I think now we're doing some work with handheld devices. Almost, there's an app for everything. So having that information in real time in your hand and not even relying on a tablet. Everybody in our unit has a handheld device. So it makes it anything you can do to create that path of least resistant results in really good things. The positives again for us was improved rapport between the respiratory staff and the medical staff, the decrease in the VAEs, the significant improvement in our spontaneous breathing trials and spontaneous awakening trials, decrease use and sedation boluses, and improvement in our overall weaning process. And again, I can't tell you all how much it improved the coordination through the multidisciplinary team in a very good way, just by using the software and putting it into folks' hands that could actually benefit from it. And the number one thing was the fact that it improved our patient care. Our focus is always doing what's best for our patients. And our current process is, we have improved communication, particularly with our infection control team. We're introducing the Messenger, which is the app that I talked about, that you put on your handheld device and have real-time information in a really small device, not a tablet that can be sat down someplace and you have to go find it. You have that, you put it in your pocket and move from place to place and have it readily available. The near real-time data is even gotten more closer and closer to really real-time information, and the multidisciplinary usage of the data is significantly improved. So that is what I have to share, and I hope you gain something from that. Maya?
Thank you, Harold. We have two questions that actually came up in the Q&A. So the first one was, what was the most significant change you made in decreasing VAP?
So the most significant change was, I think, communication. I think it was communicating that data, making sure that the data just didn't stay housed in the system, that the data was being used by the bedside caregivers. I think that was the most significant piece. It's good to have data, but like I always tell folks, because most vendors will tell you that they can produce data. And I think data is good, but it has to be useful data and it has to be accessible. And I think that with this, with the RKP and with the tablets, it became not only data, but it became useful data that was available in a timely fashion that it could be effectively used to improve patient care. And that's what we saw from the study.
Thank you, Harold.
Mm-hmm.
Another question was, can you share the dollar saving scenes with dropping the number of VAEs, and what did that do for your RT department?
So yeah, as you can imagine, when we purchase equipment and when we have software, it does not come without a cost to secure those items. And so a lot of time when we speak to the folks in the C-suite, they may not necessarily know what a VAE is. But one thing they do know is that they know dollars. So just like Dr. Cataldo said, $40,000 per VAE is significant. And we were very, very conservative and said, I think we used a figure of $20,000 to $25,000 per VAE. And when we put those numbers, and I don't have them sitting in front of me right now, but it was significant. When we and remember, we went from, I think, a 11.2% to 2% post study. When you put those dollar figures in front of the C-suite, there's a significant buy-in. Is okay, the RRO, the return on investment for buying this software, it was significantly gained back from decreasing the VAEs. So from an RT perspective, it made it easier for us to secure equipment, for one. It made us easier for us to secure equipment. It made us easier for us to secure staffing to support some of the things that we wanted to do that were not, some of it wasn't even our VAE related, but they knew that we were doing things that were wise and that were putting a huge return on the investment. They were improving patient care, but also decreasing costs for the health system.
Yeah, and I'll add to that a little bit, Harold. I mean, you talk about return on investment, which I think is important because, when you're buying equipment, particularly capital equipment, right?
Mhm.
So big purchases, big money purchases, you know, the C-suite wants to see that return on investment, right? And it's not always so easy to show them that after the fact, right? I mean, there's a value analysis committee that you present to, you create a, predicted return on investment that then usually just goes unsupported or they don't really look into it after the fact. The interesting thing about a thing like RKP is that that data is there for you. It's sitting right in front of your face. So when you introduce a technology like this that is recording data and outputting incidents of VAEs and time of mechanical ventilation in such an easy way, it's actually quite easy to then, after the fact, show the C-suite like, oh, remember that investment we made last year? This is already what we're seeing from it. And you can be conservative and put, lower dollar numbers on there. You said use 20 to 25,000. I mean, basically, with the results that you're seeing at your institution, you can put whatever number you want there. It's gonna show positively on your return on investment. So, when you're introducing a product like this to your value analysis committee, I would think that it creates a stronger argument saying, all right, not only is this our predicted return on investment, but what I'm going to promise you, the C-suite, the VAC committee, is that we're going to follow it. We're going to show you, we're going to update you. And whenever you want, you can take a report on this and see exactly what you're saving. So it's kind of a neat little addition.
Right.
Thank you both. Yeah, there are three more questions that came up actually. The first one was, what piece of data was the most helpful?
So what piece of data was the most helpful?
Yeah.
So I think that, when I talked about the clinical markers were significantly helpful. And when you go into the knowledge portal, it has a specific portion that is just VAE related. And it will give you the parameters of which a patient is ventilating in. And one of the things that we found was that, say a patient's on the night shift, and for whatever reason that patient deteriorated or something happened and it was transient, and someone turned the patient's FiO2 from 50 to 70%. The patient recovered. The patients are now sitting 99% on their oximeter. They get a morning blood gas. The patient's PO2 is 200. What we were finding was without the review of the RKP, that patient's FiO2 was staying at 70. When there was a significant opportunity to decrease that patient's FiO2 back to where it should have been. So with the RKP data, there was a lot more focus on making sure our patients were being ventilated, particularly the particular settings they needed to be ventilated at. There were also occasions when there would be patients who had significant reasons for their FiO2s to be higher. And those were the patients that really ended up with VAEs and whatnot, because it was factually and physiologically what was happening with the patient. So when you look at the RKP, one of the things I think Dr. Cataldo talked about, there's a ton of information in it, EMR. And putting all that information together in a useful and effective way, so there's not just one parameter, there's multiple parameters that are used for that VAE assessment and the rest of the knowledge portal. And it puts that information in a useful canned type of a method of looking at it. So looking at the VAE section of the RKP was probably the most effective piece for me and my staff.
Okay, thank you. So we still have time for these two last questions that are here. The first one is, you mentioned a mobile phone application of RKP, a handheld device. Can you share anything more about what it provides?
Sure. When I was talking about the mobile piece, it's actually not something you can go to. You can't go to Apple Store and pull it up. So it is a mobile application that we actually have it on iPods, and right now it's called Messenger. So we use that that app on those iPods to have this, has the same information that is on the RKP. It has alerts. So when markers are met for our thresholds, it'll make an alert. So you'll hear a little noise go off. You can look on your phone and you'll see those things pull up in real time in front of you. So if a patient is outside of what we call lung protective strategies, which are set by our thresholds, then it will alert you. If an alarm setting is met that is outside of our alarm setting protocol, it will alert the bedside therapist. And VAEs are denoted in different colors on the app. So if you can pull up all your patients and you can see maybe it's a patient that has met day one VAE criteria, and it will be yellow or orange. And then the next day, if the patient is on the second day and it may be still trending toward a VAE, it'll be red. So it's something visually that the person can hold in their hand and look at and see what's going on in real time and make adjustments.
Thank you, Harold. The last question, how long did it take to bring about this multidisciplinary cross-functional coordination in fully utilizing the benefits of RKP?
Right. And this is actually a funny question, Harold, because I think what the real question is are you just a stud, or is this an achievable thing? I mean, I agree. I mean, this sounds like a lot of work to coordinate this big thing. And how did you do it?
Yeah, so I was about to say it takes a lot of massaging, and it takes a lot of nurturing to get everybody on the same page. I will tell you that I do have the benefit of working in a facility where we do have a good multidisciplinary team. But anytime you start introducing things that go across disciplines, you don't want to, folks have silos sometimes, and they don't want to think that you're stepping into their garden. So one of the challenges to get everybody on the same page was our pharmacy team, and that was simply that when we had our first meeting, everybody was there. We had physicians, we had nurses, we had respiratory therapists, we had pharmacists, we have we're not a teaching facility, but I swear we have more students in here than any place I've worked at. We have med students from a couple of universities. We have pharmacy students from the University of Georgia, South University, Mercer University. We have students all over the place. So we had those folks in the meeting as well. And one of the things that became an issue was we run some of our infusions behind a PCA syringe through our pumps, just so we can't have any diversion of any medications. So it's a decision that our health system made. But when we did that, some of the information from the infusions was not being shared within the RKP. So some of our pharmacy friends said, well, if I don't have all the information, then it's not really telling me what I want. So you had to overcome that piece. And again, remember, we're a multi-hospital system, and we were the ones doing the beta testing and doing a lot of the things with the RKP. And we had a manual system on our sister facility. So there was a question of, do you really want a system that is telling everything? I said, well, we have nothing to hide. We're transparent. The numbers are what the numbers are. We can't go on a piece of paper and say, okay, well, the FiO2 is 50. Let me turn it down to 44. Okay, I turned it down for 30 minutes. Let me turn it back up to 50. If we did that, the RKP would say, hey, the patient FiO2 wasn't down long enough. Still going to be a VAE. So what we did to make it work was basically share the value of the data with the teams. So when we would go to multidisciplinary rounds, and the question would be, well, how's this patient weaning? What have been the settings? And we would pull up the RKP and say, here you go. Every parameter on that ventilator is trended right here on this screen. Oh, so what did the FL2 did last night? Can you tell me what the FL2 did last night? There you go, FL2, there you go. I can tell you what it did for the last 8 days that the patients have been on the ventilators right there. Oh, well, how's the spontaneous breathing trials going? Well, you have one particular caregiver who gave one patient 15 boluses, even though they were maxed out on what. How do you know that? There's the data. Oh, so again, once you showed that data, again, you had a couple of things. One of them was that Hawthorne effect, because everybody knew they're being, well, it wasn't like Big Brother, but they knew that somebody was watching what they were doing. So practice changed, and practice changed for the good. And the data wasn't just, like I said before, it wasn't just data to have data. It was actionable, useful information, and folks took value in that data that was related to them, and it worked across the team. Remember, we're not just talking about respiratory therapists and pharmacists and nurses. We're also talking about our physician friends, who are sometimes excuse me, Dr. Cataldo, sometimes a little hard to get on board. But when they saw the data and saw that we had an opportunity to wean some of our patients, 24, 48 hours before they were being weaned, they said, well, hey, let's give it a shot and see what we can do. And the proof's in the pudding and the proof's in the data. And when you see those decreases, and they're significantly clinically significant and statistically significant, you have a strong buy-in.
Thank you very much, Harold. And thank you as well, Dr. Cataldo. With this last question and these last words, we're going to end the webinar for today. I'm hoping everyone enjoyed it. There will be a replay available, so feel free to forward the link to any of your colleagues, or even to watch it again if you've missed bits and pieces of this webinar. And Harold and Dr. Cataldo, again, thank you very much. This was very interesting and insightful.
Thank you for the opportunity.
I appreciate the opportunity.
Thank you. Enjoy your day.
You all take care.